Good day, everyone. It's a great pleasure to welcome you to this masterclass on genetic kidney disease. Over the next few minutes, we will explore 6 real-world clinical cases that demonstrates how genetic testing is transforming every aspect of nephrology, from glomerular disease and tuberculosis to transplantations and pregnancy-associated kidney disease and precision medicine. The goal is not simply to identify genetic disorders, but to understand when genetic testing changes the diagnosis, alter management, and guide prognosis, and ultimately improves patients' outcomes. I'm Dr. Mahmoud Sheikh, nephrology consultant and World Kidney Academy educator. So let's get started. Let's begin with our first case. We are evaluating a 19-year-old woman who was referred because of recurrent episodes of muscle weakness associated with persistent hypokalemia. An important part of the history is what not present. She denies diuretic use, vomiting, or laxative abuse, or making common acquired causes of potassium loss much less likely. Looking at her lab findings, she has significant hypokalemia with a serum potassium of 2.8. She also has metabolic alkalosis, reflected by bicarbonate level of 33, together with hypomagnesemia. Renal function is completely preserved with a normal serum creatinine and SVGFR above 90. And urine studies provide another important clue. Rather than conserving electrolytes, the kidney continue to waste them. She has hypercalciuria and increased fractional excretion of magnesium, pointing toward an intrinsic renal tubular defect. Imaging further strengthen that suspicion. Renal ultrasonography demonstrates bilateral medullary nephrocalcinosis, suggesting chronic calcium deposition secondary to long-standing tubular dysfunction. At this stage, the differential diagnosis would naturally include inherited salt-losing tubulosis such as Bartter syndrome, Gitelman syndrome, and disorders involving the calcium sensing receptor. To move beyond phenotype alone, comprehensive molecular testing was performed using a next-generation sequencing tubulopathy panel with copy number analysis. The results are highly informative. No pathogenic variants were identified in SLEC12A3, making a classic Gitelman syndrome is unlikely. Likewise, SLC and KB testing was negative, arguing against one of the most form of Bartter syndrome. Instead, the patient carries a heterozygous pathogenic activating variant in the Cas gene. Now it's your turn to put all the pieces together, looking at the clinical presentations and the phenotype, the biochemical profile, and the imaging findings, and the molecular data. Which one of these diagnoses best explains the entire case presentation? Let's go through the possibilities. Could this be Gitelman syndrome? Or what about Bartter syndrome type 3? Or is it simply autosomal dominant hypocalcemia with hypercalciuria caused by an activating Cas mutation? Could then disease account for these findings? Finally, what about familial hypomagnesemia with hypercalciuria and nephrocalcinosis? Take about 10 seconds. Don't focus on a single lab abnormality. Instead, ask yourself one question: which diagnosis explain every finding, including the phenotype, the imaging, and the genotype, without leaving any loose ends? Let's see what you selected, and then we will dissect each option one by one. The correct answer is C, autosomal dominant hypocalcemia with hypercalciuria caused by activation Cas mutation. Let's walk through why this is the best answer. At first glance, this patient appears to have a classic inherited salt wasting tubulopathy. She has hypokalemic metabolic alkalosis, renal magnesium wasting, preserved kidney function. All features that immediately bring Bartter syndrome or Gitelman syndrome to mind. However, one finding should make us pause. The marked hypercalciuria associated with bilateral nephrocalcinosis. The combination is a major diagnostic clue. Now add the genetic data. Both SLC12E3, the gene responsible for Gitelman syndrome, and CLC-NKB, one of the major causes of Bartter syndrome type 3, are negative. Instead, the patient carries a heterozygous pathogenic activating mutation in the Cas gene. Once that result is integrated with the phenotype, the diagnosis becomes very clear. So what is happening physiologically? An activating mutation of the calcium sensing receptors make the receptors excessively sensitive to extracellular calcium within the thick ascending limb of loop of Henle. This suppresses NKCC2-mediated sodium chloride transport and reduces the lumen-positive electrical potential that normally drives passive calcium and magnesium reabsorption. The result is Bartter-like renal salt wasting syndrome, characterized by hypokalemic metabolic alkalosis, renal magnesium wasting, marked hypercalciuria, and ultimately nephrocalcinosis. Now let's briefly review the other options. Why less likely? Choice A, Gitelman syndrome, is unlikely because Gitelman associated with caused hypercalciuria, not hypercalciuria. Nephrocalcinosis would also be unusual. Choice B, Bartter syndrome type 3. certainly shares many biochemical features, but the molecular testing doesn't support it. No pathogenic CLC and KB variant was identified. Choice B, Dent disease. Should raise suspicion when you see hypercalciuria, but Dent disease is typically characterized by low molecular weight, proteinuria, progressive chronic kidney disease, and proximal tubular dysfunction rather than prominent hypokalemic metabolic alkalosis picture. Choice E, familial hypomagnesemia with hypercalciuria and nephrocalcinosis, is another reasonable differential diagnosis. However, patients usually have much more severe magnesium wasting, progressive kidney dysfunction, and pathogenic variant in CLDN16 or CLDN19, none of which are present here. So where is the take-home message from this case? When you encounter a patient with hypokalemic metabolic alkalosis plus hypercalciuria and nephrocalcinosis, resist the temptation to label the patient as having just Bartter syndrome immediately. The calcium phenotype is often the discriminating clue, and activating Cas mutation can closely mimic Bartter syndrome, yet the diagnosis, inheritance pattern, and prognosis and counseling are entirely different. Let's move to our second case. This case illustrates one of the most challenging situations in inherited kidney disease, evaluating a potential living donor in a family affected by ADPKD. Our recipient is a 31-year-old woman with genetically confirmed autosomal dominant polycystic kidney disease. She carries pathogenic PKD1 variant and has now reached the stage where living donor kidney transplantation is being considered. The potential donor is her 34-year-old brother. At first glance, he appears to be excellent candidate. His kidney function is completely normal with serum creatinine of 0.8 and SMIG-FR of 112. His blood pressure is normal and there are no obvious clinical concerns. The imaging, however, introduces subtle degree of uncertainty. Renal ultrasound doesn't demonstrate definitive renal cysts, which is certainly reassuring. However, MRI reveals two very small unilateral cortical cysts. Are these simply incidental findings that many health adults develop, or could they represent the earliest manifestation of ADPKD? That uncertainty makes the genetic evaluation critically important. Routine targeted next generation sequencing for known familial PKD1 mutations is completely negative. At this point, many transplant programs may conclude that the brother is genetically unaffected and therefore suitable for donation. But the story doesn't end there. Because the clinical suspicion remained high, ultra-deep whole genome sequencing was performed. This is more sensitive technique detected the same familial pathogenic PKD1 variant, but at a variant allele fraction of only 8%. That finding is diagnostic of low-level somatic mosaicism. In other words, the mutation is present, but only in a small proportion of his cells, making it invisible to routine genetic testing. Now let's move from diagnosis to management. You have established that this potential donor has low-level somatic mosaicism involving the familial PKD1 mutation. The question now becomes, what are the most appropriate recommendations regarding living kidney donation? Let's think through each option carefully. Option A suggests proceeding with donation because MRI findings are essentially normal. Option B recommends proceeding because routine genetic testing didn't detect the familial PKD1 mutation. Option C declines living kidney donation because the donor carries somatic PKD1 mosaicism, which may progress over time and could place the donor at future risk of chronic kidney disease. Option D proposes postponing the decision and simply repeating renal imaging in 5 years. Finally, option E suggests that donation is acceptable as long as kidney function remains excellent with an SMG-FR above 90 millimeters per minute. Take a moment and think beyond today's lab values. This is not simply a question about renal profile. It's a question about long-term donor safety, genetic risk, and responsible transplant decision-making. Ask yourself one question: which recommendations best protects a healthy donor while remaining consistent with the current principles of genetic kidney disease and living donor transplantation? I'll give you 10 seconds to make your choice, and then we will discuss why recommendations clearly stands above the other. And the correct answer is option C. The appropriate recommendations to decline living kidney donation because the donor carries somatic PKD1 mosaicism, placing him at future risk of chronic kidney disease. Let's discuss why. One of the most important misconceptions in transplant medicine is assuming that normal kidney function today guarantees long-term donor safety. It does not. Mosaic ADPKD often behaves very differently from classic ADPKD because only a proportion of cells carries the mutation. Patients may have delayed disease onset, asymmetric cyst development, preserved renal profile, and only started imaging abnormalities. However, the clinical course is unpredictable. Some individuals remain mildly affected for years, whereas others eventually develop progressive cystic kidney disease. That uncertainty is exactly why the donor should not be accepted. Removing one kidney will permanently reduce nephron reserve in an individual who already carries pathogenic familial PKD1 mutation. As transplant physicians, our first responsibility is not only to help the recipient, but also to protect the healthy donor from avoidable long-term harm. Now, let's briefly examine why the remaining options are incorrect. Option A relies primarily on imaging. Although the MRI shows only two tiny unilateral cortical cysts, imaging alone cannot exclude early mosaic EDPKD. Molecular evidence always outweighs reassuring imaging when pathogenic variant has been identified. Option B assumes that negative routine genetic testing excludes disease. This case demonstrates exactly the opposite. Routine next generation sequencing failed because the variant allele fraction was below S detection threshold. Ultra deep sequencing revealed the familial mutations that routine testing completely missed. Option D suggests repeating imaging in 5 years before making a decision. Once mosaicism has already been confirmed genetically, postponing the decision doesn't eliminate the underlying genetic risk. The diagnosis has already been established. Option E focuses on one donor excellent renal profile measuring, and its measure 112 is certainly reassuring today, but transplant decisions are based on lifetime risk, not today's lab values. Excellent kidney function cannot compensate for confirmed pathogenic mutations. So what are the major teaching points from this case? First, a known pathogenic variant in potential living donor should be considered a contraindication to donation, even when phenotype is mild or atypical. Second, ultra-deep sequencing has become an invaluable tool to detecting low-level mosaicism that conventional sequencing may completely miss. And finally, the guiding ethical principle in living donor transplantation is donor safety. When uncertainty exists regarding future kidney health, protecting the donor must always take the most important thing. The bottom line is simple. Low-level somatic PKD1 mosaicism is not a benign lab finding. It represents lifelong genetic test risk, and that risk outweighs the potential benefit of proceeding with living kidney donation. Let's move to another challenging case. This is a 21-year-old man with a history that should immediately raise concern for an inherited stone disorder. He has experienced more than 15 calcium oxalate kidney stones since the age of 8, requiring multiple urological procedures throughout childhood and adolescence. That history alone is unusual. Now add another important clue. His brother developed kidney failure at the age of only 24 and is already receiving maintenance hemodialysis. Whenever you see early onset nephrolysis occurring in more than one family members, we should immediately think beyond common stone disease. Equally important is what the history doesn't reveal. There is no inflammatory bowel disease, no bariatric surgery, no excessive vitamin C intake, and no history of ethylene glycol exposure, making the common cause of secondary hypercalciuria much less likely. Let's look at the lab findings. His serum creatinine is already elevated to 1.9 with an SVG-FAR of 52, indicating established chronic kidney disease despite his young age. The most striking abnormalities is the 24 urine oxalate excretion of 148, more than 3 times the upper limit of normal. Plasma oxalate is also mildly elevated, while urinary citrate and calcium remain within normal limits. Imaging provides another critical piece of puzzle. CT demonstrates bilateral nephrocalcinosis together with multiple recurrent calcium oxalate calculi, suggesting chronic process of oxalate deposition rather than isolated stone formation. At this stage, the combination of childhood onset of recurrent calcium oxalate stones, marked hypercalciuria, nephrocalcinosis, progressive kidney dysfunction, and strong family history should strongly suggest primary hyperoxaluria. Genetic testing was therefore performed. Sequencing identified a pathogenic variant in the EGXT gene, specifically one of the best characterized disease-causing variants associated with primary hyperoxaluria type 1. A second EGXT variant was initially classified as a variant of uncertain significance. However, segregation analysis demonstrated that the pathogenic variant was inherited from the father, the second variant from the mother. And importantly, the two variants are in trans, meaning they affect different copies of the gene. In addition, computational prediction tools constantly support the pathogenicity of the second variant. Now let's move to what I think is the most important question in this case. This question is not asking whether the patient has primary hyperoxaluria. Instead, it's asking whether we know enough to say that the diagnosis has been genetically confirmed. Let's look carefully at each option. Option A states that the patient has genetically confirmed primary hyperoxaluria type 1 simply because 2 AGXT variants are present. Option B argues that concordant computational prediction tools are enough to classify the second variant as pathogenic. Option C takes more cautious approach. It suggests that the phenotype is highly suggestive of primary hyperoxaluria type 1, but the molecular diagnosis remains formally unconfirmed because the second AGXT variant is still classified as variant of uncertain significance. Option D tells us that because both parents are clinically unaffected, autosomal recessive disease is excluded. Finally, option E recommends delaying pyridoxine therapy until the second variant is officially reclassified. Take a moment to think about this really question about genetic interpretation, not disease recognition. Ask yourself which statement is fully consistent with current ECMG variant reclassification principles, which also reflecting good clinical judgment. I'll give you about 10 seconds, and when we'll discuss why this question illustrates one of the most common pitfalls in clinical genetics. And the correct answer is option C. The patient's phenotype is highly suggestive of primary hyperoxaluria type 1, but the molecular diagnosis remains formally unconfirmed because the second AGXT variant is still classified as a variant of uncertain significance. Let's discuss why. This is where it's essential to distinguish clinical diagnosis from molecular confirmation. Clinically, the evidence is overwhelming. The patient developed recurrent calcium oxalate stones during childhood, has marked hyperoxaluria, bilateral nephrocalcinosis, progressive coronary kidney disease, and brother with early kidney failure. In addition, one well-established pathogenic AGXT variant has already been identified. Taken together, the phenotype strongly points toward primary hyperoxaluria type 1. However, under the current ECMG A and B framework, a definitive molecular diagnosis of an autosomal recessive disorders require two pathogenic or likely pathogenic variants in trans. Although the segregation analysis confirm that the two variants are on opposite alleles, the second variants remain classified as a variant of uncertain significance. Therefore, from strict molecular genetic standpoints, the diagnosis is not yet genetically confirmed. Now, let's briefly review the other options why incorrect. Option A assumes that finding two variants automatically confirm diagnosis. It doesn't. One of these variants is still a VUS, and a VUS can be counted as disease-causing allele for formal molecular confirmation. Option B gives too much weight to computational prediction tools. Certainly provide valuable supporting evidence, but under ECMG criteria, computational evidence alone is supporting, not sufficient to classify a variant as pathogenic. Option D misunderstands autosomal recessive inheritance. Healthy parents are exactly what we expect in recessive disorders, because each parent typically carries one disease allele, only one. Their normal phenotype doesn't exclude primary hyperoxaluria. And option E, perhaps is the most clinically important mistake. Should we delay treatment while waiting for genetics and laboratory to classify a VUS? The answer is no. Management should be guided by patient's phenotype, not delayed because of molecular uncertainty. In fact, the identified mutation big like 120 ARG is the best characterized pyridoxine responsive EGX variants, and pyridoxine therapy should be initiated while additional evidence is gathered regarding the second allele. So what are the major teaching points from this case? First, molecular uncertainty doesn't necessarily mean clinical uncertainty. Second, clinical management should always integrate the phenotype with available genetic evidence rather than relying on a variant classification alone. Third, if VUS is not permanent diagnosis, as additional evidence accumulates through family segregation studies, functional assays, RNA analysis, future database updates, that variants may ultimately be reclassified as significant. The bottom line, in this case, the patient should be managed as having suspected primary hyperoxaluria type 1 with a very high level of clinical confidence. Treatment should begin without delay, and ongoing efforts should continue to establish definitive molecular confirmations through further characterization of the second AGXT variant.